Brand new research is showing that the lifetime risk of dementia is now up to 42%. That is terrifying. And they're predicting by the year 2060, there will be 1 million new diagnoses of dementia per year in the US. And that is huge. Um, how do we catch it early? That's what we really need to figure out. Because if you wait until you have dementia, you're the prospects of reversing it, you can still slow progression and reverse it in some cases. But of course, when we're taking a functional medicine approach, we'd like to never develop it in the first place. So how do we prevent it as thoroughly as possible? And it used to be that dementia was just a disease of 70 and 80-year-olds. But what's happening is there's now more 30 and 40-year-olds that are showing signs and symptoms of early dementia and mild cognitive impairment. And so we need to take action to protect our brains, and protecting your brains occurs by protecting your body. And in this video, we're going to discuss these numbers that I've said so far, and we're going to discuss, and I'll show you a new test in the blood that I've made a video on in the past for easier and more accurate diagnosis. And these are strategies we can use to catch things early or hopefully never develop dementia. Let's dive into the research. All right, so here we are with hot off the press publication from Nature Medicine, 2025, January, just came out. And the title is Lifetime Risk and Projected Burden of Dementia. And what these authors did was they used a community-based prospective cohort study to look at over 15,000 people, made up mostly of Black women, 55% Black women, with at least one ApoE allele. Now, we've made videos in the past on the ApoE gene, and the ApoE gene, especially if you have an E4, ApoE4 allele, and even worse if you have double 4 alleles, that is an increased risk for dementia. So that's one genetic contribution to dementia. But if you have that allele, one or two of them, the ApoE4 allele, that does not damn you to dementia. It increases your risk. However, research has shown that up to 40% of dementia cases can be prevented or reversed through, various strategies. And so I would say the 40% would be probably more on the reversal side, because prevention, theoretically 100% of cases could be prevented if we knew what we need to do to prevent them. And we do have a lot of information on modifiable risk factors that we've talked about in other videos and have been published, that there's at least 12 known modifiable risk factors for dementia that can be addressed through lifestyle choices, etc. And so this paper, using this research, these authors estimated the lifetime risk of dementia from age 55 to 95. And they then applied the lifetime risk estimates to the US Census projections to evaluate the annual number of incident dementia cases from 2020 to 2060. The lifetime risk of dementia after age 55, based on their research, is 42%. So 4 out of 10 people after age 55 will have dementia. That's huge. And that will cripple, as we've talked about before, that will bankrupt any society. Rates were substantially higher in women, Black adults, and ApoE4 carriers, with lifetime risk ranging from 45 to 60% in these groups. Okay, so if you are female, if you are a Black adult and or an ApoE4 carrier, this information becomes even more urgent and important. The number of US adults who will develop dementia each year was projected to increase from approximately 500,000 in 2020 to approximately 1 million in 2060. So the yearly dementia numbers are projected to double in the next 40 years. That's crazy. The relative growth in new dementia cases was especially pronounced in Black adults, and we'll talk about reasons for that. And these results highlight the urgent need for policies that enhance healthy aging. And that's the key there. Whether you're Black, white, female, male, ApoE4 or ApoE3, 2, or 1, all of the strategies for healthy aging apply because none of us want to develop dementia and all of us are at risk. These were the groups that this paper found were at higher risk, but we're all at risk because we all live in a similarly toxic environment with similarly toxic behavioral patterns. And it is the combination of the lifestyle choices we're making, the environment we're exposed to, and the genetic cards we've been dealt that drives dementia risk. So, not good numbers, and hopefully these numbers motivate us as individuals and as doctors and society to do better and improve our behavior so that we don't lose our brains, literally and figuratively. So I want to review one paper from 2024 here that I've made a video on in the past that looked at blood biomarkers to detect Alzheimer's disease in primary and secondary care. So in your PCP's office, or more accurately, in your functional medicine doctor's office, because your PCP won't even know about these tests yet. The statistics say it takes 17 years for new information in the research to make it into medical textbooks. So your doctor's not going to know about this for about 20 years unless they're, staying up to date on things. And so your functional medicine doctor hopefully knows about it now. And I'm one of them who does. And so we can get to work at preventing, detecting, and reversing or preventing progression of Alzheimer's sooner. Why? Well, because these blood tests are available through LabCorp. And this paper studied these blood tests in primary and secondary care. So primary care would be walking into your PCP or your primary care physician's office. And the reason they did this is because standard ways of diagnosing Alzheimer's disease, lumbar puncture, MRIs, PET scans, different things like that, those are invasive and every test has limitations. And so, obviously a lumbar puncture is not comfortable to do. It's invasive, it brings infection risk and things like that. The MRI and the CT scans are useful, but if you're claustrophobic, that can be an issue. And they have, false negative, false positive risks, as do blood tests. But this paper compared the blood test to standard of care detection and found that the blood test is as good or better than standard of care. So as good or better than the lumbar puncture, as good or better than the CT scan. And the blood test is better than both your primary care physician and your dementia specialist. How can I say that? Well, look right here. Okay, right in this red area, the diagnostic accuracy was high. Primary care physicians had a diagnostic accuracy for dementia of 61%. The blood test had an accuracy of 91%. Okay. Dementia specialists had a diagnostic accuracy of 73%. So they would diagnose dementia accurately in their patients 73% of the time. Again, the blood test, 91% of the time. So the blood test is more accurate than our primary care physicians. It's more accurate than our dementia specialists. And it's cheaper and less invasive than the methods that they typically use, like CSF puncture, lumbar puncture, and imaging. So they conclude in this paper, the blood test alone had high diagnostic accuracy for identifying Alzheimer's disease among individuals with cognitive symptoms in primary and secondary care. So again, high diagnostic accuracy in individuals with cognitive symptoms. So these blood tests can find it early and sooner than the CSF, the lumbar puncture or the imaging sometimes, and accurately and more inexpensively and less invasively. So why isn't this standard of care yet? Well, it takes time for the research to hit standard of care, but we don't need to wait because we've got the data right here. So let me show you an example of a patient result. You can see this is a recent result on a recent patient from my office, and this is a 55-year-old female with concern for lifetime risk of Alzheimer's disease based on family history and symptomatology that she's experiencing that may fit, mild cognitive impairment and future dementia diagnosis. So she wanted to take action as soon as possible to know where is she at because again, if you wait till you get the diagnosis, prognosis is not as favorable. So this test, there's two things you want to look at in the blood. You want to look at tau protein buildup, and you want to look at beta amyloid protein aggregates. So remember last week we talked about Alzheimer's and beta amyloid and microglia and all those things. I'll refer you back to that video. But you'll remember that Alzheimer's disease, what happens in the brain is that you have a buildup of these protein aggregates. And protein aggregates you can just picture as a clumping up of protein. Think of like a big ball of yarn in your brain that's not good for you, or a big clump of spaghetti. Okay, the proteins in your brain clump up and they're no longer functional, and they are a stick in the spokes in the efficient functioning of the rest of your brain that is still functioning well. So two key proteins that aggregate or build up or clump up in your brain are called tau protein. So tau tangles develop, and beta amyloid plaques. So again, as you can see, we can test antibodies to these proteins. And if you've got high levels, you're headed towards that dementia diagnosis. So we want to catch it. And so let's look at the results here. So the results of the tau test can be seen here. Clinical cutoff value was established using samples from a patient cohort characterized with amyloid PET scan data. Okay. A tau value of greater than 0.18, okay, greater than 0.18 here, used to facilitate biological identification of Alzheimer's disease. So if you had a level higher than 0.18, so it'd be above the normal range here, then that's identification of Alzheimer's disease. Tau has been used in clinical trials to monitor patients on anti-amyloid therapy. So tau is used in clinical trials to monitor Alzheimer's patients that are using standard of care anti-amyloid therapy medications. So the tau test, if you ran that to investigate for Alzheimer's or an Alzheimer's risk, you want to be below 0.18, which this woman was. So she still has normal ranges of tau. So no risk there, or no increased risk, we should say. Those are normal levels. And then here is the beta amyloid side of the test, and you're looking at the beta amyloid 42/40 ratio. What is that? It's just two different forms of beta amyloid. And so the ratio here, less than or equal to 0.102, suggests higher probability of the patient being clinically diagnosed with Alzheimer's disease. So you want to be greater than, 0.102. Greater than 0.102 is protective, which it says right here, values above the 0.102 suggest lower probability of Alzheimer's diagnosis. So again, does that mean you'll never get it? No, but at the time, if you're greater than that number, like this person is, you have a lower probability of diagnosis. Now, does that mean you're good forever? No, right? The body and physiology is dynamic. So it means you're good right now. If you practice unhealthy lifestyles or have unhealthy exposures for 10 more years and you retest, does it mean you'll still be greater than 0.102? Maybe, but it's possible you get worse and now you have less than 0.102 and higher probabilities of Alzheimer's diagnosis. So right now, these numbers do not fit diagnosis. Precise plasma testing of beta amyloid 42 and 40 has demonstrated comparable effectiveness to traditional CSF testing and amyloid positron emission tomography scans. So what does that mean? It means this test is as effective as the CSF puncture or the PET scan, but cheaper and less invasive. When assessing the risk of Alzheimer's pathology as the underlying cause for mild cognitive impairment or dementia, it is important to consider various factors, such as medical and family history, nutritional deficiencies, neuroimaging, and physical, neurological, and neuropsychological examinations. So again, they're admitting right here that there are many factors in Alzheimer's. It's not just you have an ApoE4 allele and you're damned to it. No. Yeah, that's where family history plays in because the genetics are going to tie in there. But you might have no genetic risk, but a family history of Alzheimer's because of familial lifestyle habits that are passed on, right? Maybe your family is obese, or maybe your family is type 2 diabetic and you're practicing lifestyle strategies that promote obesity and promote diabetes and promote cardiovascular disease. Well, vascular decline drives dementia because the brain is fueled by what? Blood vessels. So if you've got heart disease, you probably have brain vascular disease as well, or cerebrovascular disease, it's called, right? Because if you have pipes in one part of your house that are bad in a closed system, you probably are going to have pipes in another part become bad over time because, again, it's a closed system. They're all connected. Nutritional deficiency, okay? Nutritional deficiency can drive Alzheimer's. Well, what the heck? I thought it was a progressive neurodegenerative disease that we can't do anything about. Well, it's going to be progressive if we stay deficient. And so, what if we find out what we're deficient in and replete those issues and optimize those nutrient levels? Well, now maybe we reverse neurological symptoms. Maybe we slow or reverse uh, nervous system decline, and we don't develop Alzheimer's. And then the neuroimaging, the physical, neurological, neuropsychological examinations, those are all things that happen in standard of care, and those are things that, need to be done as a normal workup. But we have to also include nutrition, which obviously impacts nutritional deficiency biomarkers. We have to include physical activity because movement is life, and movement is life for no part of the body more than the brain and nervous system. So we must be moving and exercising. We talked last week about the importance of sleep in the glymphatic system in that brain bath, remember? Because the glymphatic system in that brain bath each night with good sleep is what washes the tau tangles and the beta amyloid plaques away, prevents the aggregation or the buildup of them. So you must be sleeping. And then stress, of course, and is stress literally shrinks the hippocampus, which is the part of the brain that is in charge of short-term memory, and that's the part of the brain that declines and degenerates in Alzheimer's. So you see all of the lifestyle factors matter and are huge, as well as smoking and isolation or lack of community and many other factors, right? And so if we circle back, uh, hormonal dysfunction also matters. We circle back and we see, hey, the lifetime risk, the lifetime risk here for groups like women, Black adults, and ApoE4 carriers. Why women? Well, the women, one factor is hormonal changes, right? The lifetime risk after 55 was 42%, substantially higher in women. Well, what happens around and after 45 in women? They go through menopause. And so postmenopausally, their hormones are different. And if you don't go to and through menopause healthily, then your ride through and afterward is more bumpy and potentially harder. And so if you have estrogen, testosterone, progesterone, hormonal imbalances, that impacts brain, that impacts cardiovascular system, that impacts potentially the whole body. So why are women at a higher risk? Well, because the women are going to have larger hormonal swings, typically going through menopause than the men do going through andropause. Black adults. Why Black adults? Well, if they're looking, I guess here the play is the socioeconomic status, and if they're um, eating less healthy food, then they may be more prone to nutrient deficiency. Black adults have higher levels of obesity and diabetes and cardiovascular disease, which again, closed system ties into cerebrovascular disease. And so those things matter. And then ApoE4 carriers, again, there can be variance there based on ethnicity. But again, it doesn't matter if you're men, women, black, white, ApoE4 or not. We all live in an environment that is pro sugar, pro gluten, pro dairy, pro sedentary lifestyle, pro stress, pro bad sleep, pro devices, pro heavy metals and toxic environment and microplastics everywhere. So the the world is conspiring against our brains, and we need to educate ourselves on how do we push back against those factors so that we can preserve our brains, preserve our health span, and preserve our lifespan. And so that's what today is about. And we can do that through living a life at optimal and implementing functional medicine paradigm. And we can identify where we are on the risk spectrum with these brand new blood tests that are more accurate than your dementia specialist is at diagnosing. Let's open this up for questions or comments.
This is
Well,
Jet. Oh,
yeah,
go
go
ahead.
ahead. Go ahead.
I was just curious if you've read anything on other countries. Is this just the US where it's the most prevalent because of the
It,
food?
I mean, I'd have to, I think there's, going off the top of my head right now, there's a lot of work on the UK as well, but I think pretty much Western countries um, are going to pretty much fall in line with these numbers,
Okay. I was just curious.
plus or minus. But if they're living you know, a Western lifestyle that matches an American one, then, which the UK generally does, Europe, some European countries. That would be my suspicion.
Okay. Thank you.
Mhm. Maria, you had one?
Yeah. So recently I had to have an MRI on the brain.
Mhm.
And uh, if they said, oh, it's normal for your age,
Mhm.
like we don't see anything abnormal.
Mhm.
Is that is that good as far as I mean, I
Uh,
had actually my cousin's a neuroradiologist, so he read it for me.
mhm.
So I thought, well, he didn't see any type of plaques or anything else bizarre. And I'm just asking you if it's a brain MRI for looking for other things, could they pick up on dementia issues?
So there's limitations to every test, right? So the first answer would be it depends on what part of the brain they were looking at. So if it was a whole brain MRI, you're more likely to. If it was a um, brain MRI more focused on a specific area and not others, maybe not. So the MRI goes through, it'll look at the brain, but then you can slice it. So you can slice through and go see more internal structures and things. So I'd have to know, what all they looked at. But then also, every test has a limitation as to a true positive and a true negative. And so there's numbers on MRI that say MRIs until you have 40% damage, it won't show up. So
Mm.
a normal MRI would suggest, hey, you have less than 40% damage. Um, so as if we talk about, well, what's the, you just showed us this new blood work. What are the risks there or its limitations? Well, if you see here, for the tau test, the validated limit of quantification is down to 0.06. So the detection limit is down to 0.03. Okay.
Right.
So like anything less than 0.06 is um, not as firm as between 0.06 and up, right? So everything has its positives and its limits, and so understanding the limits is useful.
Well, I figured it was something in the right direction.
Yeah. Yeah, I mean, the larger question for me on with that comment, it's normal for your age. That doesn't really make me feel good because, well, you're saying normal based on the normal, if we're saying you're 45, the normal 45-year-old American, well, the normal 45-year-old American tends to be, 66% of them are overweight and on their way to obesity. So does that normal, that's common, not normal, right? It's common to get mugged in New York City. It's not normal to get mugged in New York City.
Right.
So it's common. 500,000 people are diagnosed with dementia. You know, is that normal? No. So I would want the standard to be higher, but again, in research they use quote unquote healthy volunteers, but your average quote unquote healthy volunteer is someone who walked in off the street, and the average person off the street is overweight. And just because they don't have diagnoses doesn't mean they're healthy, So for, not to depress you or anything, but with the information we have, sure, that's great. That's great.
Well, yeah, I mean, I started laughing because he says, you have a normal, healthy, blah, blah, blah for your age.
Yeah.
It's like no vascular issues, no plaques. I
Hmm.
thought, and I just started laughing. It's like great for my age, and I
Yeah.
do so much, but
Yeah.
okay. Thank
What
you.
about, yeah, what about compared to a 25-year-old, right? Or a 75-year-old, you know? So I obviously there's physiologic aging, and we're not going to look like the 25-year-old. I get that, and that's part of my argument for like the anti-aging hormone doctors that tell you, you should have the testosterone levels you had at your peak vitality at like age 25. It's like, well, no, no, I shouldn't. Not if I'm 45, And so I get that your brain shouldn't necessarily look like your 25-year-old self, but what is what's the top standard for your decade, and let's shoot for that.
Right.
Or basically what is the best what's the optimal level our brain could look given normal physiologic, aging? That's what we should shoot for.